How does giving money with no strings attached to all pregnant women in a city help improve their health and the health of their baby? Michigan is home to the nation's first community-wide prenatal and infant cash prescription program, and new research shows it's leading to impressive results.
This is built on mountains of evidence that when we trust families, when we trust women and mothers, they make the best decisions for themselves and their families.
Our guest is Dr. Mona Hanna, who's the founder and the director of RX Kids, which she created in response to the Flint water crisis of 10 years ago.
This is a really, really consequential time window. What happens in this really brief window shapes your whole life course when it comes to especially health. So this is just an upstream effort to improve health outcomes.
This is Conversations on Healthcare.
Well, Dr. Hanna, welcome back to Conversations on Healthcare.
It's great to be here with you all. Thank you for having me.
Absolutely. You say that RX Kids is more potent than a prescribed pill and that it aims to improve health, hope, and opportunity. I'm wondering if you could tell us exactly how it works and how much money are we talking about?
Yeah, so it's a really simple concept that to be able to ensure that we have healthy patients and healthy communities, that we really have to treat those root cause issues that makes it hard for especially children to grow up healthy and successful. So RX Kids is prevention at its finest. So we are addressing perinatal poverty, which is the worst period of economic instability in life course, by giving every pregnant mom in a community $1,500 in mid-pregnancy. And then once the baby's born, it's $500 a month, either for 6 months or 12 months, depending on location. So this is the poorest time in life course, but also for those of us, especially in pediatrics and obstetrics, and really anybody who understands anything about science and medicine and public health, like this is a really, really consequential time window. What happens in this really brief window shapes your whole life course when it comes to especially health. So this is just an upstream effort to improve health outcomes.
Well, one of the things that really is very striking is that this is a no strings attached program, which gives the mom, one would think, a lot of agency in this situation to decide what they need. But I wonder, does that mean there's no requirements about how the mother spends the money on maternal health needs, on baby care, or on whatever she feels is necessary at that time? Tell us about that.
Yeah. That's a great question. So this program is really built on dignity and trust and really mountains of evidence. So this concept of child allowances or paid leave for moms, this is done around the world. We're the only peer country that doesn't have maternity leave, and we're the only peer country that doesn't have child allowances. 70% of countries in the world have unconditional child allowances. So this is built on mountains of evidence that when we trust families, when we trust women and mothers, they make the best decisions for themselves and their families. So some families need help with rent, some families need help with diapers, some families need help with transportation to get to the doctor, and some families need to pay their bills. So this empowers families to make their own decisions, which is contrary to a lot of the other programs that we have out there that are often paternalistic and really assume that we know what's best for families. But that's not actually built on evidence. And in addition, those programs are really bureaucratic. They require lots of staff and lots of administration to figure out who's in, who's out, what are people spending their money on. And this kind of upends all that by respecting the science on cash transfers and really, once again, empowering families.
That's great. Margaret, I think those of our listeners who've been watching us for a while remember the Flint, Michigan water crisis that happened, and we were glad to interview you after your research exposed the Flint-led water crisis and the effect on children. And interestingly, there's a connection between that crisis and this program, and I wonder if you can share how that connection came to be.
Yeah, Mark, thank you for that. So I think a lot of folks think of Flint and the water crisis as like this failure, right? Like that place that poisoned its children. And from the moment of really uncovering the crisis, our focus as a community has been to really be remembered by what we've been able to do next, to think out of the box creatively of how can we do better as a society of really caring for our children. So we've been able to put into place so many different interventions to not only mitigate the impact of the crisis, but really kind of share our best practices. Rather than reacting to problems, how do we prevent problems? So for example, a lot of my work has been around Infrastructure Act, getting the nation to replace lead pipes and strengthening laws and paying attention to issues. And that's all been amazing. And it's had wonderful ripple effects across the country. But there continued to be this frustration that despite all this goodness that we've done, especially in Flint, especially after the water crisis, we've once again been unable to treat this root cause issue that continues to make it really hard for our kids to grow up healthy and successful. So in the same spirit of resisting poisoned water, which very much that Flint water crisis story is, that it was about using science to speak truth to power, about exposing this crisis, about building a better tomorrow for our kids. In that same spirit of resisting the status quo, came this program where we are no longer okay with our babies, being born into poverty. We're the richest country in the history of the world. Poverty is a policy choice. We can do better. So in that same spirit, this program was created. And the really neat thing is that I get calls almost every single day saying, hey, we want to be like Flint. And never would I thought 10 years ago that other communities now want to be like Flint. But you know what? That was always our intent.
Speaking of doing better, was there improvement in, I know there was an allocation issue on money on the lead pipe issue. Did it find its rightful place in terms of the investment that needed to be made?
So our pipes have by and large been replaced. It took about a decade. It took a long time. It took a while for the money to get there. But that, beautifully has raised the nation's consciousness on drinking water issues, on lead in water, environmental justice issues. So wonderful, amazing things have happened since then. But yes, our pipes are by and large replaced. Our water is much better. But we as a nation still need to do better in terms of strengthening, especially environmental and public health regulations. So we can make sure that every kid, no matter where they live, turns on their tap and is confident in what they're drinking.
Well, all power to you and Flint, because I remember that conversation as one of the hardest conversations we've had in the many years that we've been doing the show. So congratulations for moving it in this direction. But, people want to know about the results and, appreciate the research, whether it was on the water crisis or this. So JAMA Network, the Journal of the American Association, Network Open, has published a study that found that after RX Kids launched, prenatal care increased, and there was a decrease in infant deaths, which is the most, of course, that we want to see. So maybe you could describe the findings in detail. Tell us a little bit about other associated findings. We're all ears.
Thank you, Margaret. I'd love to. So this is so exciting. I'm still a boring academic, so I love doing the research. Although, cash for kids and families with young children, there's mountains of evidence, but we knew that we needed to bring out our own evidence as well. The really neat thing, and I think the most important data point, is that we have a near 100% take-up rate for the program. And we do data matches with birth certificates, so we know how many babies are born in a community, and we can kind of compare them to how many babies are in the program. And it's near 100%. So that in and of itself is pretty amazing. And we actually have a paper forthcoming on that. If you compare other programs in this window, like WIC or home visiting programs, they have about a 50% take-up rate for WIC or a 20% take-up for home visiting programs. So the most kind of exciting thing is that everybody who should be in the program is in the program. And because we have a 100% take-up rate, our research can really lean on the big administrative data. The big data, for example, from vital records, which is birth certificate data, which tells us a lot. And the research that you're talking about that was published in JAMA Network Open looked at that big administrative data, looked at the babies born from Flint, and compared them to about babies in 21 control cities and compared them to babies in the state. So this is really, robust research with control populations. And what we found is that when RX Kids started in Flint, when it started in January 2024, at a population level, not just a sample size of like 20 or 30 or 100, at a population level, we are seeing improvements in prenatal care access. Mamas are going earlier in the first trimester, even before the program starts. They're going more often, so there's more of an adequacy of prenatal care. And we have less of no prenatal care, so less mothers who have had no prenatal care. With that same vital records data, we're also seeing significant population improvements in birth outcomes, which, as you said, is the goal. We have less premature babies, less low birth weight babies, less NICU admissions, and that already is translating into healthcare cost savings. In survey research that we've done, which relies on surveys also with control populations, we're seeing improvements in family financial stability, which one would expect by giving families, cash during this window. We had a significant decrease in evictions, which is phenomenal because even the threat of eviction in the community can lead to preterm delivery. So we had less evictions, we had more food security, and nutrition is so important for pregnant mamas and babies. We had improvements in maternal mental health, like postpartum depression and less stress and less anxiety. And then we also had improvements in what we touched on earlier. Our mamas feel more empowered. They feel more respected. They feel more loved, which was, once again, also part of this work. So lots of great big data showing population improvements and some of these stubborn measures. It's often hard to improve preterm, delivery rates, and we're doing it, and we're doing it fairly quickly.
I just want to underline that this is the kind of study that one can only hope for with a large data set. Pretty much everybody's in the data set.
Yeah.
You implemented the program in 2022. You looked at big data in 2024, and you're reporting on it in 2025, which is almost unheard of in highly meaningful research areas like this.
Yeah, no, we're grateful. We've had wonderful data use agreements and, all those checks that we have to do. But we give almost a quarterly feed from the state. So we get the vital records, and we're trying to share back this data as quickly as possible. And it's our ability to share this data that has allowed us to really expand the program. So it started in Flint, but as of, a few hours ago, we just this morning launched in 6 communities in Wayne County. It's our biggest expansion ever. Wayne County is where the city of Detroit is. So we're now in 17 communities in Michigan. So that research has really been able to inform policy, and you can't sit on this research. It was our goal to be able to share back data as quickly as possible.
Remind our listeners how big Michigan is. 17 counties. Is that half of Michigan, all of Michigan? And what are your plans for expansion?
My plan is world domination, or at least national expansion. So Michigan has, I don't know, I think it might be 53 counties or 83. Michigan has 83 counties. We have 100,000 babies born a year. Wow. We, at this point, we have prescribed almost $20 million to about 4,000 families. The Michigan budget, which passed a couple weeks ago in Michigan, included $270 million for this program to expand over the next 3 years. So we hope to touch about 1 in 3 families over the next 3 years.
So it's really got bipartisan support. It sounds like people.
It does. Yeah, I think. Yeah, I'm sorry.
What's your secret sauce for that?
Well, it's babies, right? It's babies. So we have tremendous bipartisan support because everybody loves babies. Right. This program is also really time limited. So it's not a long program. It's administratively super efficient, which appeals to a lot of folks who don't want big government. But one of the other data points that we've been able to share is that it's an economic development program. You can think of it as a trickle up program. Money is going directly into the hands of mamas and families. It's being spent locally on childcare and small businesses and grocery stores. We even had a report come out a couple of weeks ago. It's creating jobs because, hey, the childcare people need to hire more people and the landlord needs to hire a property manager. The list goes on. So we're creating hundreds of jobs, and it's a stimulus to local economies.
So it's a force multiplier. Every dollar equals $2 or $3.
100%.
Yeah.
Right.
Yes.
And the savings on NICU admissions, which I think we saw in
That's right.
Colorado
Yeah.
with some of their
Right,
interventions.
and child
birth
welfare.
outcomes.
We're preventing child welfare involvement. That system is really expensive. So we're preventing dependency on government, and we're boosting local economies. But really, most importantly, we're improving health.
Well, I'm going to go back to the research for a minute. Research in the American Journal of Public Health stated that pregnant mothers fared better on multiple measurements related to emotional well-being than mothers who didn't receive the cash. And tell us about that and pull the thread on the impact that has, not just on the moms, but on the kids.
Yeah. Not in that research, but really built on that research is what we hear from our families. Our mamas who say that they can breathe, that a weight has been lifted off their shoulders, that poverty and not having enough to make ends meet is expensive, and it takes away their bandwidth and time, and it is a massive stress for the families. I see moms all the time in clinic who say, like, I don't have to choose between paying rent and buying diapers. I don't have to choose between putting food on the table and, getting formula for my baby. So all of these beautiful statements from our mothers is translating into the data, which was in that American Journal of Public Health article that shows moms have less postpartum depression, less stress, less anxiety, and improvements in well-being. And that is great for families. That's great for health. And that's absolutely so important for children.
Well, and it's so important to children's development, right?
Absolutely.
Maternal depression, postpartum depression.
It's critical for kids to grow up in an environment where they feel safe, secure, that is stable, that a parent is there and attentive. But when a family is struggling, that's very difficult. I'll give you one example. Before we started this program, I had a newborn coming into clinic, was a premature baby who was just 5 pounds and was coming in for the 4-day checkup. The baby was just 4 days old, and they were no-show. They didn't come to clinic. So the office staff tracked him down, and the mom had to go back to work at 4 days of age. So she had just given birth 4 days ago, and she had to go back to work because for her, the choice was, it was more important for her to make ends meet than to go to that important doctor's visit. So this is giving families a cushion, a little bit of breathing space to be able to be there, maybe to stay home a little longer or pay for childcare, to breastfeed longer when maybe they weren't going to go to the doctor's visits, to get the vaccines, to, all these different things. And we're seeing that play out in the data.
That's great. We're big followers of Robert Putnam. He wrote the book Bowling Alone, said basically people are bowling the same amount, but they're bowling not in leagues, they're bowling alone. And he's very focused in on community and civic engagement. I'm wondering what has other research found about payments helping to drive civic engagement and long-term economic gains?
Oh, I love this question. So on Election Day last week, we released a report on civic engagement, our impact on civic engagement. So in that American Journal of Public Health article, we also had measures of trust in there. And we found that our ARCS kids exposed mothers had more trust in government and in healthcare systems than non-exposed mothers. And then, I think of this program like a way to restore that social contract, right? That relationship that individuals have, especially with government, and how there's been such lost trust and people don't believe that government's working for them or helping them. So we actually worked closely with a political science professor who is an expert on voting research. And he looked at what was happening in Flint compared to other control populations and compared to the state. And in the November 2024 election, women of childbearing age in Flint voted more than older women, voted more than men. They voted more than in similar demographics in other cities. And then when we compared our participants to their voter files, our ARCS Kids Mamas voted more than non-ARCS Kids Mamas. This is amazing. This is restoring democracy. And we're going to be looking at other measures of social cohesion and what's happening at the community level. But it's a bit like a panacea. Like, I don't like to use that word, but here's this really, really simple program that is impacting all these different domains, including civic engagement.
Very, very impressive. I think you said 3,600 families have been reached already, 11 Michigan communities, $15 million in direct support. You've got the bipartisan support. I think that people would love to hear your strategy for how you went about this, because in these particular times we're in, I think everybody's looking for some opportunities for bipartisan contribution and support back, but it doesn't happen automatically. So, Baby, you obviously learned a lot during the water crisis. Yeah. Baby, tell us a little bit about your strategy to get that support in this instance.
Yeah, I think, like you said, this is a bright spot. This is a solution when people are really yearning for solutions. It's addressing so many of the polycrises that folks are facing, that states are facing. Number one, affordability. That is top of issue for families. How can I afford eggs and groceries? And it's addressing that issue in, once again, one of the most expensive times in a life course. Babies are expensive. They need a lot of stuff. So it's addressing the affordability crisis. It's addressing the housing crisis. We have, data on improved housing stability. It's addressing the childcare crisis, the ability of families to pay for childcare. It's addressing maternal infant health crisis. We have some of the worst outcomes in this nation when it comes to maternal infant health. It's addressing that. So I think it's economic development. So I think when we are able to frame it in all these different ways as a one single solution, it appeals to all kinds of folks. It appeals to libertarians who were champions of cash transfers from the 1940s with Milton Friedman. They love small government and efficient government. It appeals to progressives. It appeals to, the pro-life folks. It appeals to the natalists. So all of these different folks are interested in some different elements. I would say another strategy is, as much as we share the science of this work, I think we also, we share the stories. And I think that ability to share the real stories of real families who are struggling, who care for their children and their babies just as much as we all do, has also kind of humanized this as much as possible. I was in Mississippi last week. Mississippi just declared a public health emergency because of rising infant mortality rates. They are the poorest state in the nation, and their babies are dying. And the Republican legislature asked me to come to testify about a solution. And people are ready for shovel-ready solutions, right? Here is something that is working, that's based on evidence, that is really simple, and that's plug and play. We are ready to go anywhere in this country as long as those funds are at the table.
Well, I think it's because the program's authentic, and you are as well. Your voice is very important. Margaret, I was reading the New York Times, I think in the last 8 or 9 months, and I was shocked when I read an article about another study about programs called Baby's First Years, which showed little effect after providing cash payments to mothers. And this research looked at programs in New York City, New Orleans, and a few other places. How do you respond to that negative research, or maybe it's not negative research, but to to those outcomes? What are you doing that's different?
Oh, several things. So that was a study that looked at kids at 4 years of age, their developmental milestones in the Baby's First Year program, which gave $333 to families, and it was a randomized controlled trial. Other families got $20. So there was no prenatal cash in that program. That just started at birth. But the biggest issue was that research. I feel so bad for them. It happened during COVID. It happened during the pandemic. When there was an infusion of cash. Not only was there the expanded child tax credit, there was the economic stimulus payments. So that was a massive confounder. And COVID also impacted children's development. So that was another part of it. So that was the biggest reason. I would also say that they were underdosed, and we learned from them. So they gave families $333, not adjusted for inflation. So we are giving our families $500 postnatally. So it didn't start.
And also, you're doing educational work that they weren't doing as well as one of the 2 or 3 things that they were not focused in on.
But the most important thing is it happened during COVID. So the dose was too low. It was a time of massive disruption. People got cash. It had developmental impact. And it was a small, means-tested, randomized control pilot.
Yeah.
We are at scale. Our intervention arm, or the number of people, our participants, is already 10 times greater than that. So science evolves, science learns. It's unfortunate that article got so much attention, because I think a lot of people want to be like, oh, Cash for Kids doesn't work. Quite the contrary. It's worked for decades, if not a century, in other places.
Right. And I would
suggest most recently, it worked when we expanded the child tax credit in 2021, and millions of kids got unconditional monthly cash allowances. We dropped child poverty to the lowest level ever, and tons of outcomes happened. So that should be our most recent learning point.
Yeah.
And I'll take I skew to the optimistic side of the house. As long as the research was sound, it produced valuable findings. The underdosing piece is a critical piece to know. At this level versus at this level, there's a different, no different than in clinical trials. So good for them. And also let's not have another COVID pandemic. Yeah. But after talking about that, I want to ask you about the future, right? So over the next 3 years, I think you have plans with RX Kids to expand to lots of new communities, reach 100,000 babies, perhaps cover a third of all births in Michigan. I assume that means regardless of economic income group. Yep. And very importantly, you've developed a roadmap or a startup guide for municipalities, I guess, or counties that wish to implement this. So what else do you need to make this work? And how does a community that is far from Flint take that manual and get that work done? Have you really laid out a roadmap for people?
Yeah. So, we're in 17 communities right now, urban and rural. After being successful in Flint, we expanded to 5 counties in the eastern Upper Peninsula of Michigan, very rural, very different, mainly as a proof point that this is also possible in rural communities where there's a lot of challenges. There's a lack of healthcare, lack of birthing hospitals, lack of nonprofits. So it was really important that we also were able to be successful there. So there's more research coming from kind of all of our sites. Our sample size is exponentially continuing to grow. And we have lots of resources on our website, rxkids.org, to learn about how we can spread this to other places. We would love to share, once again, this plug and play program that is for entire geographies. We don't call it for poor people, it's for high need places. This is a place-based intervention that really allows us to address the compounded adversity of growing up in a poor place, poor environmental quality, or, unsafe places to play, lack of grocery stores, all of these things impact health. So we want to be able to do this at a place-based level.
Well, there's no question in our mind, you're a visionary. And tell us, how does RX Kids fit into your broader vision of what pediatric care should look like in America?
Oh, thank you. So, as a pediatrician, these are the kinds of things I've wished for from the beginning of seeing that first patient. I love seeing for patients, but I got easily frustrated when I was taking care of a kid admitted with a gunshot injury and not being able to address gun violence. Or I had a kid, admitted with an asthma exacerbation, intubated, because we weren't talking about air quality. So for me, optimal pediatrics is also very much addressing those social drivers of health. And, when it's frustrating not to be able to do that. We actually did a study this summer with a medical student who surveyed our pediatricians and asked them about burnout and wellness in light of this program. And the doctor said, finally, I have something I can prescribe that is really going to help my patients. And it's even like an antidote to physician burnout, that they can do this. So, doing work like this, to me, addressing holistically everything kids need, not just at the bedside, is what pediatrics is to me and why I went into this profession.
Well, Dr. Hanna, I think that's a great note to end on. Thank you for joining us. Thank you for the work that you've done in the past, that you're doing now, and what is to come. And thank you to our audience for being here. Just a reminder, subscribe to our videos on YouTube, find us on Facebook and X, and please share your thoughts and your comments about this program. Take care and be well. This This copyrighted program is produced by Conversations on Healthcare and cannot be reproduced or retransmitted in whole or in part without the express written consent from Community Health Center, Inc. The views expressed by guests are their own, and they do not necessarily reflect the opinion of Conversations on Healthcare or its affiliated entities.